So, students, good afternoon to you all. So, we'll have an interactive discussion on applied neuroanatomy of the spinal cord. Let us all think that we don't know much about spinal cord, and we'll start afresh because uh, it appears as if we know, but then we really apply it onto the patient, we may not remember exactly. The best way to do is that you start saying that let me start afresh, and we'll go on discussing about the various aspects of the neuroanatomy of the spinal cord. The learning objectives for this is we want to define the spinal cord syndromes, and after understanding the anatomical principles, and sometimes MRI may help us, but mainly what the myelopathy says is that it's a term coined in late 1800 to describe spinal cord dysfunction. And if I can say that myelopathy remains a clinical diagnosis, and etiology requires integration of clinical neuroimaging and laboratory parameters. The important thing to note is that clinical myelopathy findings may have normal MRI, as you can see in HIV associated myelopathy. That's why I keep saying myelopathy is a clinical diagnosis, and MRI and various other tests may help us in establishing the etiology if we know that. So before we start knowing that, let us understand the dimensions of spinal cord. The spinal cord, as you all know, is enclosed in a vertebral column, and it protects the relatively shorter spinal cord. The spinal cord length is around 45 centimeters. It's slightly longer in men, that is 18 inches, than women, 17 inches or 43 centimeters. Just look at the diameter. Diameter is only half inch, 13 millimeters in the cervical and lumbar regions, and in thoracic it is only 1/4 inch, 6.4 mm. So whatever diagrams we are seeing, the cross sections and all look very big, and we imagine so many things, but the real diameter is 13 mm in the cervical and lumbar regions and almost 7 mm in the thoracic area. The cord varies an average APM transverse diameters actually from 8.8 to 12.4 at C2 to 8.7 to 14 mm at C4 to 7 in the C7 region, because these diameters are very important for us to establish cervical canal stenosis. The cervical enlargement is found C4 to C6 because of the brachial plexus. Similarly, we have an enlargement in the lumbosacral region where the diameter is varies between 15 to 17 mm. The lumbar canal stenosis results from an AP canal diameter of less than 12 mm in some patients. So, but however, 10 mm is stenotic and may be a primary source of symptoms. So, all these diameters are calculated especially on this plain X-ray or the CT scan of the spine, and MR may not give rise to optimal measurements, but it can be used. But we usually do it on the plain X-ray. So these are the diameters which are very important and which you should keep in mind about the diameters of the spinal cord. At birth, the spinal cord typically extends to the lower border of the L3. By adulthood, its tip is usually at the L1 and L2 vertebral disc level, or it can end either at T12 or go down to L2 levels. And there are about 31 pairs of spinal nerves. 8 are cervical, 12 are thoracic, 5 are lumbar, 5 are sacral, and usually 1 is coccygeal. The first pair of spinal nerve roots will exit between the skull and the atlas, this is C1. The next 6 above, they are respectively numbered vertebrae, that is C2 to C7, but C8 is above T1 vertebrae. The remaining spinal nerves will exit below the vertebrae of the corresponding number. So we in learning about spinal cord, we need to learn the myotomes, the dermatomes, and sometimes the vascular supply of the spinal cord, very essential. So we'll have to learn a bit about the vertebral column, because we will be discussing the extradural compressions, intradural, extramedullary, and intermedullary compressions in compressive myelopathies. There are non-compressive myelopathies which have various etiologies. So this is the spinal cord, which is the cervical region, thoracic and the lumbar, vertebral and intervertebral disc, and the sacrum and coccygeal, and this is the cauda equina. We may have to read separately cauda equina and conus medullaris lesions. We'll have some questions towards the end, about 8 to 10 questions are there, which we can interact very well. And these, so if you look at the anterior view, it looks like this is the, as if it's a horse tail. Now you can see that cauda equina that's coming down, and this is the conus medullaris, and you can see that clearly the lumbar enlargement that is seen here. And this is here about 15 to 18 millimeters, and here is the cervical. So we can have lumbar canal stenosis and cervical canal stenosis. The thoracic cord is very thin. It is about 7 millimeters in the cross section. And there are, in addition to that, motor nerves and sensory nerves, that is anterior root, and that is ventral root and dorsal root. You have intermediate lateral column, which supplies the sympathetic neurons and parasympathetic neurons. So the parasympathetic is craniosacral outflow, and the sympathetic is T1 to L1. These are the intermediate lateral column. You can see the, which supplies the heart, increases the heart and increases the contractility and arteries of the upper thorax and lower thorax and innervates smooth muscles. So the various autonomic functions are also mediated through the supply in the spinal cord. And this is what is the cauda equina, and S1, S2, S3, S4, S5, and L4, L5 vertebral and spinal nerves, which you can see. Main important thing is to differentiate, to identify cauda equina lesions, which may be asymmetric on onset with the asymmetric sensory loss on the sacral region, which will differentiate towards the later part of it. Another important thing to know and not to get confused is the anatomy of the vertebral column, which initially I was myself finding it difficult to understand, but slowly you pick up. This is the posterior aspect, which has got a spinous process, and these two are helpful in the movement. There's a transverse spinous process, and this is the articular thing. This is the vertebral arch, and this causes the protection. This is the support. We'll see more of this anatomy and the disc that can get protruded and cause the problem. And you can see that superior articular process, the transverse process, the spinous process, and inferior articular process, and the lamina here, and inferior vertebral notch and superior vertebral notch, and the pedicle and the body of the vertebra. So in this vertebral column is that thin, very thin spinal cord lies, and this vertebral articulate, and actually this is the intervertebral disc, and this is the intervertebral foramen, and the disc can protrude into the spinal cord in the axial section, you can see, and that can cause problems. This is the inferior articular process of the vertebra, and this is the superior articular process, and there may be some inflammation in between. This is the joint, that facet joints, which can get inflamed, and so cause pain. And the lamina is here, and laminectomy process is the removal of the lamina, or the cutting of lamina, will enlarge the spinal canal. So, and now this is a major part. You can see that this is an interesting diagram, which I think one now everybody should know about this diagram. And this is what is a disc herniation. Nucleus pulposus is, uh, it may compromise the spinal canal and cause the compression or put pressure on the nerve to cause pain, radicular pain. So that if the canal is very narrow, then it may cause a compressive myelopathy also. Calcification of the posterior longitudinal ligament canal. This is the posterior longitudinal ligament which can calcified, and anteriorly placed. This is the ligamentum flava. This is a posteriorly placed ligamentum flava. Hypertrophy can cause again spinal canal narrowing and myelopathy features. So this is the posterior part of the vertebral body and placed anteriorly, and this facet arthropathy, and which we can see in the reports, that facet arthropathy and uncovertebral joint hypertrophy can happen in the cervical region. So this is that area. So these are the important aspects which one keeps in mind. And what is this space which we are looking at this place, and what is this space? And see, this usually, we have compressions. Yeah, anybody can tell? Extra dural space. An extradural space, there the only emergency in spinal cord disorders is extradural abscess. And just remember that it's very important, and this is easily accessible, and it causes a severe destruction within a short time. And extradural abscess is a real emergency in spinal cord disorders, which can cause a picture like transverse myelitis and fever and local tenderness. It has to be, it is, this space is easily lesioned, and you can take out the pus and cure with antibiotics. So the various spaces that are around the spinal cord are also important for us. This is the epidural space, and there are a lot of venous fluxes are present here. And this is the subdural place and subarachnoid space. And this is the dorsal root ganglion. And see, most of us initially we were not knowing what are rami and how the plexus is formed. You just understand this: distal to the dorsal root ganglion, both the ventral and dorsal roots join to form the nerve in the intervertebral foramina, and soon after it gets out of that, it divides into anterior primary rami and posterior primary rami. The posterior primary rami will supply the paraspinal muscles, and the anterior primary rami join to form the plexus, brachial plexus, and lumbosacral plexus. And the spinal cord, you all know, is covered by leptomeninges, that is pia and arachnoid, and over and above that is the spinal dura mater and dural sheath. These are the spinal meninges. And so this is in brief the anatomy that is surrounding the spinal cord. And the dorsal root ganglion takes the sensory input usually, and the ventral horn is goes to the motor, that is the spinal nerves, which is the motor. So the Bell Megendi law says that the dorsal is always sensory and ventral is always motor. So this is the spinal cord is organized with the gray matter located centrally and white matter located peripherally. So they are, the white matter tracts are placed anteriorly, laterally, and posteriorly, and they are called funiculi. The gray matter that is surrounding the central canal is also divided into laminae, rexid laminae, and there are various neurons are situated here. Antihorn cell, and these are on the ventral root. The posterior root has got sensory neurons, and there is an intermediate lateral column. And there is also a group of neurons called proprioceptive neurons or Clark's column. So, and as I say, the posterior aspect is the dorsal column and the lateral column and the anterior column, which we can see the intermediate lateral. And uh, what happens is the sensory information that is coming from the lower limbs, it as far as proprioception is concerned, that is vibration and joint position sense, it comes up to dorsal root ganglion, that is a peripheral process conducting this information from periphery to the dorsal root ganglion, and from there it enters the spinal cord and ascends up ipsilaterally up to nucleus gracilis and cuneatus, and from there it crosses to opposite side. This is the first order neuron. The second order neuron is formed at the cervicomedullary junction and crosses and ascends up to thalamus, where the third order neuron takes it to the parietal cortex. So these are the three order neurons that conduct the proprioception, whereas the other spinal pain, prick, pain, and temperature are conducted again to the dorsal root ganglion. Here, the central process at this level or a few levels up ends at the substantia gelatinosa or rexid laminae 1 2, and from there the second order neuron starts and crosses in front of the central canal and ascends up in the spinothalamic tract and goes up to the thalamus, and there it comes a third neuron which goes to the parietal cortex. So there is a slight difference in the conduction of the sensory information, and that's very important because the spinothalamic tract fibers which cross in front of the central canal also have a lamination, temperature being the medial most and the pinprick and temperature slightly outside. So it's very important for all the spinal cord disorders that you should check the temperature sensation. And this is the intermediate lateral column which will give rise to the neurons that are conducting, that are doing the autonomic nervous system function. So this is cervical, thoracic, lumbar, and sacral regions, the gray matter distribution. So whenever you look at the MRI in the axial section, you should try and find out the lesion where it is. Is it in the gray matter or is it in the white matter? This is very important for us to understand and differentiate various disorders. The posterior gray column, that is you're processing the proprioception, and this also has some interneurons and relay neurons. The relay neurons means the posterior columns, while they are ascending, they give tweaks to the Cox column nuclei or posterior nuclei, and which are very important for conduction of the proprioceptive information to the cerebellum. The lateral gray matter is autonomic preganglion, thoracolumbar sympathetic, and sacral parasympathetic. And anterior gray column has cervical and lumbar enlargement. So these are the main issues here, and this we have seen. The these neurons are, there are also neurons uh, which function at the spinal cord segments, and each spinal segment you can conceptualize having a dermatomal distribution, a myotomal distribution, and angiotomal distribution. And these various 31 spinal segments, they have to function in correlation with one another. So how do they do that? Apart from that, there are some neurons, short, intermediate, and long propriospinal neurons, which connect from one spinal segment to the other segment, and those are present at the junction of the gray matter and the white matter tracts, and they connect various spinal segments and short segments, long segments. So they usually help in the posture and balance of the, and they act on the paraspinal muscles and axial muscles and maintain the erect posture also, and they integrate the function of the various spinal segments. And you see, this is the what I am telling, pain and temperatures, they have come. Project, I am taking a class, can I call you back? So the pain and temperature of fibers will cross in front of the central canal, and they ascend the spinothalamic tract, ascends to the brain. Now, and as the spinothalamic tract reaches the cervical spinal cord, the lamination places the sacral fibers to the outermost region, and inside is the cervical region. So intramedullary lesions, they have a sacral sparing if they are in the cervical region. If a pressure is being applied from outside in this, the cervical canal onto the spinal cord, then the sacral involvement is called involved, and that is sacral involvement. So the sensation testing over the sacral area is very, very important, and this is what the ipsilateral uh, fibers that are taking the dosage. Rajat, I am taking a class on this thing. Can I call you back? Hello? I am taking a class. I'll call you back, please. Okay. Right. Okay. So this is the ipsilateral and contralateral, and this anatomy is very important for understanding the Brown-Sequard syndrome, which we'll discuss in some class. So the dermatome maps are very vary and they overlap. You have to test with light touch and pin. Pin should be tested with single pokes, not repeatedly. Use face as a control. That's important. So to remember dermatomes, you have to practice the dermatomes, and whenever you take a bath and when you are washing yourself, you can identify your dermatomes, where your C3 is, where your C4 is, where your C5 is, C6, C7, and T8 and T1. So like that, you have to identify these dermatomes, and there are various important issues for localization of the lesions, and you have to look for a sensory level. If you are looking for a compressive myelopathy or non-compressive myelopathy, a sensory level will help you in localizing that problem to the spinal cord. So you have to remember there is no C1, a C2, C3, C4, and C3 is the collar area, and C2 is the suboccipital region. C4, what we call, is on the shoulder area, and the applet area we call, and C5 on the lateral aspect. And so these things, and I'll show you independent diagrams so that you can remember it very well and practice that and in understanding. This is the C2 which you have to test. If you have to test, you have to test with a one prick, not repeated pricks, and this is C3, and this is the C4 dermatome, and you can see that C6 and C7 and C8, C5 the lateral aspect of the upper arm, especially in the deltoid area, T1 and T2 dermatomes, and you can see the T3 or the T4 is the nipple level, and T6 is the costal margin, and almost T10 is the umbilicus level in between, and T12 is the groin. And so if you have a level, then you can think that if you have a sensory level, that's a very important point towards the spinal cord pathology. And you can L1, this is L2, and middle of the L3, and this is a middle malleolus is L4, and between the great toe and the second toe is L5. So you just remember these important points, and this you can keep and examining, because it it makes your life easier to identify and to localize. If you remember these dermatomes clearly, and this is S2, and this is S1, and S3 and S4 S5 are in the perianal regions. So the sacral sensations are to be tested. If you are suspecting a cervical myelopathy, you should look for whether there is sacral sparing or not, or if you are looking for cauda equina or conus medullaris syndromes, then you will have to look for the sacral sensations. Very important, and this we have already seen. So, and that brings us to the, I will not go into details of muscle supply, but the functions at various joints you can establish by elbow flexion is C5, and wrist extension and C6, and elbow extension is C7, finger flexion is C8, and finger abduction is T1. So you can integrity of the C5, C6, C7, C8, T1 can be tested by elbow flexion, wrist extension, elbow extension, finger flexion, and finger abduction. So that will give you an idea whether there is any problem in this myotomal. These are the indicator functions. The lower limb, similarly, L2 is hip flexion, L3 is knee extension, L4 is ankle dorsiflexion, L5 great toe extension, S1 ankle plantar flexion. So you should remember this. This grossly should remember and do the functions actually, and recall them at the correct time, so that the segmental features may help in localization. That is especially pain. The pain can be in spinal cord disorders, it be radicular pain, which is a pain that is in the distribution of the dermatome, and it's a piercing sudden pain which is exacerbated by maneuvers which will increase the intracranial pressure, like coughing, sneezing, and because a sleeve of subarachnoid space surrounds the root, that's why you get a lancinating pain and aggravation by the maneuvers that are increasing. And the pain can be local pain, the skeletal pain in the extradural compressions, and there may be spinal tenderness at the time, there may be a paraspinal abscess, or there may be a gibbous formation, and that's also another pain which you can encounter. And third is the funicular pain, which is a ill localized gnawing type of pain. You don't know where it is coming from. That also is because of the spinal cord pain. Other pains which you have to differentiate are inflammatory pain, which is more in the morning, and it eases as the morning improves, and it's because of the inflammation, various arthritic conditions. And the other pain is degenerative pain, which is more towards the evening, and morning they were all right. So that's another type of pain which you should understand, whether there's degenerative pain. And a band like circumferential discomfort is suggests again that it's a spinal cord pathology. And as I already said, there may be a sensory loss of pain at the level of the lesions in the spinal cord. There will be element signs as well as a sensory level, but sensory level can be a false localization because of the crossing of fibers. The sensory abnormality, if it is at T6, the pathology can be anywhere above C6. So the dictum is that if you got a sensory level, you have to scan the whole of the spine above the sensory level, and the at that level you will have lower motor neuron signs, and below that you got human signs. The dorsal column's deficit is ipsilateral to the lesion if it is a brown sequoid, and contralaterally you have pain and temperature disturbances because of the crossing of the fibers, as I have discussed. Lateral corticospinal tract deficits is also ipsilateral to the lesion and below it. Suppose you are examining on the right leg and you find that there is weakness, and you have found that there is disturbance in the vibration sense and joint position sense, please carefully examine the other leg for pain and temperature loss, because that's how the Brown-Sequard syndrome can be diagnosed. The spinothalamic deficit, as I said, is a contralateral to the lesion, but the cord has so much more of clinical and functional importance. So these are these hard lines. Some of these things may always work, may not, but you keep remembering them and look for other signs as well. So this, as I said, the tracts have got ascending tracts and descending tracts. And ascending tracts are conducting the sensory information from periphery, and so they are distributed into the lateral spinothalamic tract and ventral spinothalamic tract and ventral spinocerebellar, dorsal spinocerebellar tracts, and these are in the lateral part, and these are very important because we were discussing in the cerebellar disorders also the spinocerebellar tract importance, which enters into the cerebellum through the inferior cerebellar peduncle. And as I discussed, the fasciculus gracilis and cuneatus, these are carrying the first order neurons. They are going carrying first order neurons till the nucleus in the cervicomedullary junction. And these are carrying the second order neurons, this the spinothalamic tracts. And so they are already crossed, these are not crossed. And the descending tracts are usually the lateral corticospinal tract, that's important. In the lateral funiculus, you also have company to the lateral corticospinal tract, that is one coming from the reticulospinal region, the reticulospinal tract, the other one is from the red nucleus, the rubrospinal, lateral rubrospinal tract. And the anterior part you have ventral corticospinal tract, which is about 10% of the fibers, and the tectospinal and vestibulospinal tracts, and medial reticulospinal tract. Why we should know all these tracts? The importance is the distribution to the anterior horn cells and the control of them. And if you look at the cervical and lumbar enlargement, the corticospine, the major crude movements are controlled by the rubrospinal and reticulospinal tracts, and the fine movements are controlled by the corticospinal tracts. In fact, C8T1, the muscles are directly connected to the cortex, and that's why the fine movements are performed. Whereas the crude proximal muscle movements, and these are mainly by the other tracts that are coming from the brain stem, that is the reticulospinal, rubrospinal, and vestibulospinal and tectospinal tracts. They perform the proximal muscle and crude functions in association with the corticospinal tract, and the axial and posture is mainly by the vestibulospinal, tectospinal tracts. And so there is no role for minimal role for corticospinal tract. That's why you lose the fine movements in the hands whenever there is a corticospinal tract disturbance, especially when it is in the cortex. So this tracts the origin, the fixation, and we have already discussed. So again, the gracilis fasciculus and cuneatus, the dorsal root ganglion, and the internal arcuate fibers decussate, and they are coming from the posterior column, and they reach the thalamic, that is the second order neuron reaches, and they have fine touch, vibration, proprioception, and this is very important function for understand what's happening in the environment to the body. The anterolateral, that is spinothalamic tract, and the Bell-Megendie law says that the dorsal horn is purely sensory. Okay, and the spinocerebellar tracts also are very important. As there is a posterior spinocerebellar tract, the cuneocerebellar tract, the anterior spinocerebellar tract, and this is connecting from the lower limb and this is connecting from the upper limb. These are also uncrossed, but they cross towards the end and they reach the cerebellum on the ipsilateral side. The other is the rostral spinocerebellar tract, joins the anterior spinocerebellar tracts, and this also, so unconscious proprioception, that's what is being mediated by these spinocerebellar tracts, which function through the Cox column nuclei, and so the conveying the information from the body to the cerebellum. So these are the descending tracts: lateral corticospinal, anterior corticospinal, rubrospinal. We have already listed them. The reticulotectospinals, which are coming from various parts of the brainstem. So now we come back to this anatomy again. This is a durameter. This is the leptomeningeal circling. Though if you have a case of pyogenic meningitis, don't think that that meningitis is restricted only to cerebrum. It can spread to the spinal cord also, especially in tubercular meningitis, where you get arachnoiditis because of that reason. Arachnoid matter is also there. The pyometer is closely, encircling the spinal canal, and this is the denticulated ligament, which is the pyometer that is that is attaching the spinal cord laterally, and we have seen the ligamentum flavum, and also the posterior longitudinal ligament which is present on this side, and these are the vertebral vessels, and this is the epineural sheath of the spinal nerve, right? We have seen this, and this the importance of this is that this is the annulus fibrosis and nucleus pulposus, which can get into and cause a lot of pain. So whenever prolapsed intervertebral disc is there, the main symptoms are radiculopathy features. There will be a pain, there may be mild weakness and a loss of reflex, but they don't cause the pyramidal tract features unless there is underlying cervical canal stenosis or lumbar canal stenosis. So multiple disc protrusions along with narrow canal can give rise to myeloradiculopathy features. That's what is to understand. And this is what the denticulate ligament, which is formed by the pyometer. These are the anterior root filaments. And again, if you are asked a question, you see the posterior ramus. The anterior ramus is this. So once the posterior root ganglion is there, that is the dorsal root, ventral root, they join, they form the spinal nerve, which again divides into posterior ramus and anterior primary ramus, and the anterior primary ramus join to form the brachial plexus and lumbar sacral plexus. And this is what I was telling, the gray matter that is divided into rexid laminae 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 in the surrounding the central canal, and they have got motor neurons anteriorly placed, intermediate cell column, that is a sympathetic ganglion, and the sensory distribution in the 1, 2 and 3 levels. So apart from that, this is the Clark's column of neurons, and apart from that, as I said, there are some propriospinal neurons which give rise to the axons, short axons, intermediate axons, and long axons, and causing forming the propriospinal connections between the neighboring spinal cord segments, and that's very important. And you see the posterior column things that are coming, and you see the type 1, type 2 mechanoreceptors are coming to the rexid lamina 4 and 5 and 6. The nociceptors and thermoreceptors and mechanoreceptor visceral, they are coming to 1, 2 and 3, and they they end here. The second order neuron here crosses to the other side. So that's important of the rexid laminae, and in large figure, that's all. So the crossed and uncrossed, which we have already just revised, that the posterior spinocerebellar tract and rubrospinal corticospinal tract, lateral corticospinal tract, and anterior tract, this is the spinothalamic tracts. And so we have these are crossed or uncrossed, which you have to say crossed at this level, and partly crossed at, and some uncrossed are the posterior columns, and that's why you should understand the. Okay, so you see the pain, temperature on the leg, trunk, arm, and neck. So the lamination will help you in remembering that the outermost spinothalamic lamination at the neck is the sacral region. So you can see this is a motor lamination. Here motor also has got lamination, and you can see the outermost part of this thing is a flexor, hand and foot, extensors, hand and foot. Then as you towards the medial side, you get laminations that will innervate the axial muscles, and see central, ventrolateral, dorsolateral, retrodorsolateral. That's how they are described, and they extensors of the trunk, flexors of the trunk, they are medially placed nearer to the central canal, and the extensors of arm and thigh, then the forearm, and then the hand and foot. So the outermost are subserving the function of the fine movements of the hand, and these are the proximal muscles and the axial muscles. So that's how the distribution is depicted here. These are the flexors and these are the extensors, and this is the this is a small diagram which is being shown here, right? Right. So we have already seen this. We will not go into this, and we have seen this. Now the blood supply of the cell. The blood supply is this axial region, and you can see the aorta is supplying, and there is an anterior spinal artery and two posterior spinal arteries. And there is an exam question for the DNB students and DM students. What is the blood supply of the spinal cord? So you should understand what are the various branches and which are coming and supplying, what are the intercostal arteries, what are the radicular arteries, what are the radicular medullary arteries. Let us look at this medial medullary branch of the anterior spinal artery. This is this. The anterior spinal artery is formed by the vertebral artery, and the posterior spinal artery is also coming from the vertebral artery, but there are two posterior spinal arteries which usually are incomplete, and I'll show you another diagram. Posterior segmental medullary artery, and these arteries give branches which are centrifugal and centripetal into the spinal cord gray matter, which is only 113 millimeters. And see how micro sized these are, and supplying oxygen and glucose to various neurons. And you can see that there are these radicular, this is the Adam quiz artery, and these supplement the supply to the anterior spinal artery. So there are intercostal arteries which are joining this anterior spinal artery and supplying. In addition to that, there are some big arteries that are coming. Some arteries are very big, and they're called radicular arteries, radicular medullary arteries, and one of them is the Adam quiz artery at the L1 level. So there are some watershed areas in the cervical and thoracic region and the lumbar and thoracic regions where if there is a ischemia, you can have ischemic infarct also. And so that's the importance of knowing the vascular supply. And as you see, these are the anterior spinal. This is the commissural artery, and sulcal commissural artery is giving branches into the spironchima. Anterior radiculomedullary artery, this is a segmental artery, that's what I was telling. The posterior spinal artery, posterior radiculomedullary artery, and this diagram which you'll have to draw in the exam if it is asked. So arterial supply, again we have already seen this. And the watershed areas which I was mentioning around the T4 level, there is a watershed area. So if any individual has a cardiac arrest, there may be a infarction in this area, and the great artery of Adam Quiggs is around the L1, L2, and there is infarction here if there is any ischemic process. And these are the real, more picturesque distribution of the branches, the pile artery plexus, and how the anterior spinal artery gives rise to branches that enter the spinal cord and supply the radiculomedullary artery and the artery of Adam Quiggs, which is very, very important in the sacral region. And there are also veins, and so these are the total plexus, and the veins also gone. And one of the important venous plexus is the Batson plexus, which is in the epidural space. And this vertebral plexus is important because it connects the abdominal organs and abdominal supply to the brain, and so metastasis can spread from the Batson venous plexus above into the spinal arachnoid space and up. And this is the branch which so the artery is very important. And only to clarify it more clearly, I have put more diagrams in this. So Batson venous plexus is very important, and these are the venous drainage of the spinal cord. They follow all the arteries, and they 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 drain craniad, the posterior external plexus, and the anterior and posterior longitudinal sinuses, the lumbar veins. So there's a two-way direction, one towards the cranial and one towards the caudal end. Also the venous drainage takes place. Why we should know is because they may develop intradural arteriovenous fistulas, and these can cause compressive myelopathies. So various types of vascular malformations can cause around the spinal cord and cause compression. And these are the types of fistulas which I show here, and I'll show next diagram also another fistula that's coming. And this is the spinal, this is what it is. This is a one, you can see that it is a radicular artery here, and this is the radiculomedullary vein, which is a tributary of the coronal venous plexus, and the nerve root, which you can see here. And so if this one enlarges and compresses the spinal cord, this is a dura mater that is cut and opened and shown to you that what is the AV, dural AV malformation, which after excision is not. So this AV malformation will cause compressive myelopathy, and it doesn't, only 10% causes acute manifestations. Otherwise, it's a dorsal myelopathy which will progress over case of 4 to 6 weeks to 2 months. And so the distribution of neurons, which I was telling, the spinal motor neurons of anterior horn cell, the autonomic neurons, which will cause meiosis, hydrosis, urinary incontinence, bowel incontinence, and you'll come across these problems even after spinal anesthesia. This is a spinothalamic tract, which is the ipsilateral and contralateral, which we discussed again. The spinal cord syndromes. Now, this is the central cord syndrome. This is the anterior spinal artery and the hemicord. These are the main. I'll show you another diagram which is much more elaborate. You can see the central cord syndrome, which gives rise to dissociate anesthesia. Here, the motor manifestations are late. Here the metamorphism, but the bladder and bowel disturbances are early. That is the characteristic of intramedullary distribution. And here you have the brown sequoia type of distribution. The depression, the half hemicord is involved here, and as I said, ipsilateral disturbances in the proprioception, and the motor weakness, and contralateral disturbances in pain and temperature. This is the anterior spinal artery syndrome, which will spare the posterior columns, and so you have only temperature, pain, disturbances along with weakness. And you can have a dorsal cord syndrome, either dorsal or dorsolateral, which is subacute combined degeneration and tabes dorsalis and other copper and copper deficiencies. This can cause on HIV also the dorsal. So these are the main syndromes which we come across, and the some of them we can understand more clearly if you see this. Uh, so, what are the main etiological factors for intradural extramedullary compressions? And that's what usually cause the Brown-Sequard syndrome. This is meningiomas and schwannomas, and these will cause even dumbbell tumors. They can extend into the intervertebral foramina and cause. So, the clinical manifestations of intradural extramedullary are characterized by radicular pains, and radicular pains, and also the asymmetric onset progressive disorder with motor weakness and sensory disturbances, and also when this pressure increases and goes to the other side, you'll have disturbances in bowel and bladder. Unilateral pressure on the autonomic features of fibers will not cause the bowel bladder disturbances. Only when it increases to that level, that is the time when they have to be operated. So that's one other catch point about the Brown-Sequard syndrome. And you see, this is the anterior spinal artery syndrome, which involves the corticospinal tracts as well as the anteriorly placed tracts, that is spinothalamic, and sparing the posterior columns mostly. Okay, and the same thing which has come again. And so what type of manifestations this individual can have? You see this MRI, and this is C2, C3, and C4. What are you seeing here? 9 of you are there. Somebody talk, no? Are you able to? What will be the clinical picture in this case? What will be the clinical picture in this case? There will be lower motor neuron. Yeah, bolo.
Posterior columns will be involved.
Posterior columns will be involved. It's in cervical. Now you may come across Horner syndrome also. See, we have to think ki at that level there will be LMN, and below that there will be UMN features. So there will be spasticity, there will be posterior column involvement, there may be involvement of the sensory pinprick and temperature sensations also. So that's a cervical spondylotic myelopathy. But this, what are you seeing here? What are you seeing here? This individual presented with suboccipital neck pain. On examination, there are some nystagmus, downbeat nystagmus, and some ataxia and a sensory loss or the C3, C4 level. Dissociate sensory loss. What are you seeing here?
Syringomyelia.
What else? Okay, syringomyelia, that's good. Not complete.
Tonsil, cerebellar tonsil herniation.
So what else? What do you call that?
Arnold Sherryman.
Yes, you have to look, pick up that ACM. ACM is a diagnosis. So you can have hemicord syndrome, complete cord syndrome, which you see in the transverse myelitis, central cord syndrome, which you can see in syringomyelia, or hyperextension injuries, and where you have posterior column syndrome, posterolateral syndrome, anti-horn syndrome. So these are various syndromes that we can come across. So now, right. So any confusion about the tract lamination and distribution? Any questions you want to ask in this? And what is it showing here in this picture? This is an intramedullary lesion. Crossing spinothalamic tracts are involved. So in this case, if you don't examine temperature, you will not be able to pick up. What is dissociate sensory loss? What is dissociate sensory?
Pain,
Hmm.
pain and temperature are lost, whereas touch is intact. Touch, joint position, vibration, all are intact.
Not touch. Touch has got a dual conduction pathways. Okay, so you depend mostly on pain and temperature loss and preservation of vibration and proprioception. Okay, this is the early one. So in intramedullary, the motor manifestations are late to occur. See, this is a lesion which has increased in size, then only it can cause the motor manifestations. And this is a combined system degeneration which you see in the how will you diagnose this case? And suppose it's a B12 deficiency. What will be the clinical features of B12 deficiency as far as neurology is concerned? When will you suspect that this is a subacute combined degeneration of the cord? Whenever you have
Joint
spasticity.
position, vibration.
Yes, what else?
Sensory
There is
ataxia with the plantar extensors.
absent of ankle jerk. So you should have spasticity with absent ankle jerk and upgoing plantars.
Upcoming
So
plantars.
what are the conditions where you lose ankle jerk along with upgoing plantar? One is subacute combined.
SACD.
That's okay. That's we already said that.
Friedrich's ataxia.
Friedrich's ataxia. Next.
Yes.
So if you
Tapes
have a
dorsalis.
Tabes dorsalis, only dorsal column, only dorsal root ganglion. It will not cause.
Yeah. Sorry.
What else? See, it could be a myoradiculopathy at features. No, if you have a spinal cord along with involvement in the lumbosacral region
Yeah.
of the
Yeah.
degenerative
Yeah.
disease, which you can have the anterspinal syndrome, right? So the foramen magnum, the region, we got a occipital and neck pain, and you have lower cranial nerve signs, downbeat nystagmus, and so downbeat nystagmus is a very important localizing feature for that. And so you should be able to examine the eyes and what are the eye signs in the cervical spine or spinal pathology. What are the connecting signs and what are the eye manifestations in cord disease? Any cervical, what will you look in the eyes if you are suspecting a cervical or thoracic myelopathy?
One is
Non-compressive.
Horner syndrome.
One is
Routine
Horner,
investigation.
Horner syndrome. Yes. What else?
Uh,
Only Horner syndrome. Horner syndrome is localizing. Anything else?
Downbeat nystagmus.
Down say next. Eye movements. Okay, good. Good. Next.
Optic atrophy in B12.
Optic atrophy in B12. Very good. What else? Yeah, good. You have other diseases, no, like tuberculosis, sarcoidosis. What do they cause? What the tuberculosis is associated in the eye?
Papilledema.
Papilledema, but papilledema is secondary to raised ICP. Any other
Raised
clue?
edge.
Any other clue? Any type of
tuberculosis.
conjunctivitis? Any type of conjunctivitis?
Oh, oh.
Flickannular,
Rectangular conjunctivitis.
rectangular conjunctivitis.
Ah,
Then you may have iritis and iridocyclitis, irregular people,
yes.
right? Synechiae, anterior and posterior
Yes.
synechiae. And so various other things can happen depending on that. The thoracic cord, why we should know about thoracic cord? Thoracic cord has got the canal is very narrow. So all the compressive myelopathy is rapid very progressively. The characteristic feature of compressive myelopathy is asymmetric onset and progressive disease. If onset is symmetry, that is characteristic of usually non-compressive myelopathies. What are the characteristic features of extradural compression?
Ten-
We have
bony tenderness, bony pain.
bony pain. What else? So we have identified two or three features of interdural extramedullary, that is meningioma and schwannoma. The extradural compressions can be because of infectious processes, that is tuberculosis, epidural abscess, and pyogenic infections and fungal infections. Or it can be because of tumors, primary bone tumors and secondary bone tumors, and which is more common is secondary metastasis. And what is the most common primary malignant tumor in the extradural compression? Primary malignant.
Meningioma.
Myelomas.
Myelomas, excellent. So that's multiple myeloma is only primary
Yeah.
malignant tumor that's important in extradural compression, and secondary metastasis is more common from
Yeah.
prostate, lung, and various
Prostate.
other regions. And the benign tumors are either rare, osteomas and cardomas and things like that are rare. So that is the extradural compression. And third cause for extradural compressions are from the bony canal. What else can cause compressive myelopathy? So you have identified infectious processes, you have identified neoplastic processes, benign, malignant, and degenerative processes. You should have cervical canal stenosis with multiple disc prolapse, and that's one of the causes. And anything to do with the bone, again, anything which you can think, any trace element cause myelopathy, any trace element, fluorosis.
Fluorosis.
Oh,
You should know
fluorosis.
fluorosis. Should know fluorosis, right?
Yes.
So these
Yes.
are the causes which I mentioned just now are the causes of extradural compression. Interdural we have already discussed. Now intramedullary causes of intramedullary pathologies of compressive nature. Intramedullary. So you should remember intramedullary causes.
Ependymoma.
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 Yeah.
Next,
Syringomelia.
Syringomelia. Yes.
syringomelia is not a tumor.
Okay.
Ependymoma agreed. Gliomas,
Yeah.
right? Gliomas, ependymomas. Anything else you can think? Tuberculomas and cysticercosis. These are also face occupying lesions, isn't it? So they can also call that, right? So what are the causes? How do you identify the conus medullaris? Conus medullaris syndrome. How do you identify conus medullaris and cardia equina? What are the features of conus medullaris syndrome?
Initial involvement of bladder and bowel
Okay,
with extensor plantars
okay.
Early bladder.
and early
Early.
bladder and
What are the
extensor plantars
hmm. what
with
are the what is the etiology for conus medullaris usually?
Demyelination.
No, it is malignancy
no,
deposits. See, usually conus medullaris
secondaries.
is secondaries. So they cause bowel
Secondaries.
and bladder distribution. And what happens at sensory level? Sacral sensory
Usual
loss,
sacral.
symmetrical
Yeah.
sacral sensory loss. There may be patulous sphincters, and the ankle jerk is absent, but the knee jerk is present because
Present.
right. So they are not both the jerks are absent. What's the features of cauda equina?
Asymmetric
Both
weakness.
just
Mhm.
root pains, element
Root.
sign.
So makes the lot of pain.
All
Uh, it's a chronic disease. Usually, cauda equina is a chronic disease. It is asymmetric, associated with wasting. There may be fasciculations, wasting, weakness, and lot of pain and unilateral asymmetric condition. And so this is usually a fixed deformity of the bony canal. So cauda equina has got an asymmetric sensory loss in the sacral region. So that's how we differentiate, and you can read it more. The cauda equina has got a radicular pain, asymmetric lumbosacral region loss, marked asymmetric lumbosacral weakness, and sometimes bladder dysfunction, but it's late. Lumbar disc disease, trauma, epidural metastasis, and etc. will come. Here, the conus medulla flaccid bladder dysfunction early, bilateral saddle sensory loss, mild bilateral lumbosacral element weakness. The weakness is not a very major issue here, and it is trauma, epidural metastasis, or abscess, and that's more important cause for this. Okay. Right. So this is differentiating features from the extramedullary to intramedullary, which we have already seen. The radicular pain distribution in the dermatomal distribution, and here it is the funicular pain, that is poorly localized pain. The sensory deficit is contralateral loss of pain and temperature here. Here it is dissociation of sensation, patchy distribution, and more marked sensory the pain and temperature loss here. They are less marked in intramedullary. Lower motor neuron involvement, segmental at the level, and this is widespread here, atrophy and fasciculations. UMN, it is early and below the level of the lesion, and the involvement in intramedullary is late, and muscle stretch reflexes are increased early and markedly. That is because of the spasticity. They are late and minimal, and trophic changes are marked in intramedullary lesions. These are the important features. We look at the conus medullaris and cauda. The spontaneous pain is not common or severe here in conus. The bilateral, symmetric, or perineum and thighs. Here it is a more prominent symptom and severe radicular type, unilateral, asymptotic, or asymmetric over perineum thighs. Sensory deficit, as we discussed, saddle distribution, bilateral, symmetric, maybe dissociation of sensation. Here it is asymmetric. The motor loss is not marked, and the fasciculation may be present symmetric. Here it is marked loss, and the atrophy may occur. Usually there will be no fasciculations here. The reflex loss, only Achilles reflex is absent here. Here both patellar and Achilles, that is knee and ankle jacks, are absent, and here bladder and rectal are lost in conus medullaris. Both are involved early. They are late in cauda equina. So these are important things. Examination, it will be asked. The sexual function, ejaculation and erection are impaired. In conus medullaris, they are less marked. And sudden and bilateral onset, that is conus, and it is gradual and unilateral and chronic onset in cauda equina. So now the questions part. Which of the following best describes the anatomy and functions of the anterior horn of the lateral horn of the spinal cord? Hello? Yes. Carries light touch, vibration, sensory information from the legs. Contains, this is the intermediate lateral horn of the spinal cord. I'm so sorry. Cell bodies are the preganglionic sympathetic neurons, not affected in hemicord syndromes. Primarily located in the lumbar spinal cord, supplied exclusively by a single posterior spinal artery. Anatomy and functions of the lateral horn, the ventral horn, the dorsal horn, the lateral horn, or you can call it the intermediate lateral horn. What describes first?
Primarily located in the upper, in the lumbar spinal cord,
Wrong.
and
Next.
preganglionic sympathetic neurons.
Only one. B is correct. That is
Ye,
contained.
ye,
Oh, okay.
Yeah, no.
B.
B. Lateral horn means intermediate lateral column, right? That is because of this
Yeah.
involvement of the parasympathetic neurons, right? The lateral horn of the spinal cord contains the cell bodies of the preganglionic sympathetic neurons, primarily the thoracic and upper lumbar segment of the spinal cord. Lateral horn side is at the risk for injury with hemicord syndrome, and depending on the level of the injury. The anterior spinal supplies the anterior two-thirds of the spinal cord and would likely to be vascular supply to this region also. A 46-year-old woman presents to the emergency department for evaluation of lower extremity weakness. Examination is notable for spastic weakness of both legs. In addition, the patient is asked to sit up from the supine position. Movement of the umbilicus upward towards the chest is seen. Which of the following is the most likely localization of this patient's lesion? What is this movement? What is this sign called?
Beaver sign.
Beaver sign.
So what does
Viewers.
it say? Cauda equina, conus, lower cervical, lower thoracic, or upper thoracic?
Lower thoracic.
Lower thoracic. All agree with that? Okay. So lower thoracic. Beaver sign is due to relative weakness of the lower abdominal muscles, T10
Lower
to
abdomen.
12, and upward displacement of the wings. Next, a 35-year-old man presents to the emergency department weakness and numbness of lower body following a knife wound to the mid back, and a hemicard syndrome is suspected. Which of the following signs or symptoms would be expected in this clinical scenario? And you read the sign: autonomic dysfunction, contralateral to the side of the injury, beaver sign, loss of pinprick sensation,
Loss of pinprick sensation contralateral to the side.
contralateral to the side. Very nice. That's the thing which we have been discussing, right? and that's a Bourne-Sequard syndrome that we have already discussed. So next question is vitamin B12 deficiency myelopathy, copper deficiency myelopathy, human immunodeficient virus vector myelopathy are all classified as involvement of which of the following spinal cord structures?
Dorsal column.
Lateral and
Dorsal.
dorsal column.
Lateral and dorsal
Lateral.
columns. So somebody said dorsal columns exclusively. No, that's wrong. It's lateral and dorsal columns.
Dorsal.
That's correct.
Okay.
Lateral and
Both.
dorsal column. Myelopathy due to B12 and copper deficiency, HIV and HTLV1 myelopathy, adenomyelin neuropathy all affect both dorsal and lateral columns. You should keep this in mind when you have to discuss this case. You have to read and keep a short notes about all these differential diagnoses. Exclusive dorsal column involvement is in tabes dorsalis. Okay. 48-year-old woman present with breast carcinoma develops subacute bilateral weakness and urinary incontinence. Sensory level is T10 to pinprick. MRI thoracolumbar spine is normal. Now, what will be your next step? Lumbar puncture, paraneoplastic panel, MRI brain, MRI cervical spine. Tricky question.
Paraneoplastic.
Okay.
Paraneoplastic panel.
Hmm. Any more?
Data. Yeah, paraneoplastic.
You agree to that? See,
Yeah,
you remember what I said about the sensory level in a spinal cord. You
T10.
have to go
MR,
all
MRI C spine.
yes, that's correct. So you have to really look at the spine above the level because of the lamination of the spinothalamic. In the anterior spinal cord, the sacral fibers are more susceptible to compression. So you have to look at the spine in the thoracic region. Okay. This individual had a fall with neck in hyperextension. What type of abnormality he will have? See, he has got a problem here, no? He's got a problem. There's a problem here, neck. So what will be the type of injury he will suffer? Fall with neck in
Whiplash
hyperextension.
injury.
Whiplash.
Whiplash
So
injury.
that's okay. That is a name for that. But what clinical features will he have? What type of
Posterior
spinal
cord.
cord syndrome he will have?
Posterior cord.
Oh no, oh no,
Anterior spinal artery syndrome.
no, no. You see, there is a hyperintensity here in the gray matter. Are you able to see?
Mm.
Yeah,
Yes.
yeah. This is
Yes.
it.
Yes.
Yes, you are
Oh,
seeing, no?
yes.
Yeah. It causes central cord syndrome. So
Central cord.
hyperextension with a fall will cause central cord syndrome.
Central cord.
This what you see. This is how it comes. With the fall of hyperextension cord. Somebody, will you please mute the thing? Okay, this is central cord syndrome, trauma, syrinx neoplasm, involvement of the upper limbs and sparing legs, and suspended dissociate sensory loss. Okay, so that's what is okay, right. Next question, we'll see. Interesting. A balance disorder. Now, what do you see in this MRI? Anything you see?
Rapid tear.
Hmm?
Subacute combined degeneration.
Yeah, that's nice. Very nice pickup. Very nice pickup. And this balance disorder is a clue, and there's got the white matter abnormalities. And as I said, in the spinal cord, you should always look at the central gray matter and surrounding white matter. Now, both are very important. And this is what is the spinocerebellar tracts are degenerated along with the posterior columns in subacute combined degeneration. Okay. B12 deficiency, copper deficiency, and sometimes nitrous oxide anesthesia, and neurocephalus, and sometimes dorsal ganglionopathy because of paraneoplastic and Sjogren's and basic. So these all will have dorsal column loss. Now the blade has entered. This is the injury towards the neck, and he has got this problem here and this problem here in the spinal cord. So again, you have Brown second, right hemiplegia, right Horner syndrome, right loss of discriminatory sense, left pin temperature below C7, left leg proprioceptive loss. And you agree this Brown-Sequard syndrome? What is this? What do we see? Clinical features and what is the diagnosis here?
Extramedullary intrusion.
No, first identify what are you seeing? A ring lesion?
Ring enhancing lesion,
Ring enhancing lesion, no? So where is it
57.
located? Where is it located?
Intramedullary,
Hmm.
conus.
Yes, it's in the towards the end of the spinal cord. Spinal cord usually ends at L1, isn't it? Right. What will be the clinical features of the diagnosis? Conus medullaris, sphincter failure, incontinence, pelvic floor weakness, and numb feet. Right. What will be the clinical features in this case?
Coda equina,
Cada equina
Severe,
syndrome. Yes.
severe radiculopathy,
Radicular features. That's correct.
L4, L5.
That's correct.
So,
You said no asymmetry pain. Yeah.
yeah.
So the main differentiating features between CARDA and conus are pain. You ask yourself whether pain is there, weakness, symmetry, bowel bladder involvement. These are important, but that's it. That will click them. How long the cervical spinal cord can go normally, and what do you see in this case?
Normally it go up to D12.
Hmm. D12.
Here,
Hello. So what do you see? Okay. So this is tethered cord syndrome associated with spina bifida, thickened taut phylum terminal, lower extremity sensory motor symptoms, back pain, bowel bladder, and it can worsen with growth. And there may be some tough hair and leg deformities and scoliosis. So general examination is very important in these conditions. You have to look for in general examination. You have to look for neurocutaneous markers, and one of the important thing is lumbosacral hair tuft. This is a tethered cord syndrome. Usually it is L1 that happens. Here it is L3 that is, and there will be fatty tissue and a tethering of the phylum. Phylum will be thickened. There is thick phylum which can attach and it will give rise to, as the growth happens, there will be problems. So now you see a 16-year-old boy presents with progressive bilateral lower extremity weakness, numbness, and with difficulty walking for the 2 months' time. He reports worsening over the past 5 days, and this morning, when he woke up, he was unable to move the legs and he felt numb from his trunk down. His examination shows significant weakness with spasticity and hyperreflexia in the lower extremities. He has a sensory level at T2. And I'll show you the MRI, and then you say which are the following is the most likely diagnosis. Right? This is the MRI. Okay. See the MRI, and yes, you want to see the question? I'll go back. No problem. Now you have to answer this question. Is it acute transverse myelitis, spinal cord infarct, cord compression from metastatic tumor, epidural hematoma, meningioma with spinal cord compression? So if you want to see the question,
epidural hematoma,
there's a worsening over the past 5 days.
epidural hematoma,
Yeah, now you look at the MRI. Epidural hematoma, that's nice. That's correct. So intradural extramedullary tumor compressing the spinal cord. The tumor is located C7T1 and it's dural based. Meningiomas are the one of the most common intradural extramedullary tumors, and they are non-glial neoplasms, and that's why. Now this is a whether it is epidural hematoma, and that happened because he had a fall or something, and does not have an acute transverse myelitis that we know, and maybe sudden onset usually affects the anterior cord, that is spinal cord, that is anterior spinal artery syndrome. Metastatic tumor has more subacute presentation. You know that this patient, for the degree of compression seen on MRI, epidural hematoma also presents rapidly with an acute compressive myelopathy syndrome manifesting as spinal shock. So most likely the diagnosis is intradural extramedullary meningioma, because you can want to go and see again. There is a history of 2 months before this. 2 months history. So this is a intradural extramedullary compression, and that has worsened all of a sudden. 70-year-old man complains of back pain, lower extremity weakness, sensory deficit to all modalities below the mid-abdominal region for the past 3 days. Since onset, his neurological manifestation have progressed and rapidly, such that is paraplegic on the day of evaluation. His MRI is shown. So now we'll see the MRI, but this is only 3 days story, and we have to identify.
Transverse myelitis.
Yes, so and one of the choices you have to pick up now: an episode of hypertension, recent aortic manipulation, atherosclerosis, dural AV fistula, use of warfarin atrial fibrillation. You want to see again? You'll see clearly.
Use of warfarin for atrial fibrillation.
Look at this. So MRI shows epidural collection and consistent with epidural hematoma here. The most common initial symptom back pain, followed by development of myelopathic syndrome. So the warfarin is caused the hematoma. Of course, dural AV fistula we have already discussed. It causes the insidious and progressive myelopathic syndrome. Atherosclerosis, aortic dissection, the manipulations are associated with ischemic infarction of spinal cord. So it's not AVF. It is the epidural collection that has caused this problem. 69-year-old man presents with 6 months of gradually progressive lower extremity weakness. So which of the following is correct? This is a 69-year-old man with 6 months progressive lower extremity weakness, and this is the MRI. What are you saying?
There is spondylotic disc prolapse.
It is cervical spondylotic myelopathy. Cervical
Myelopathy.
spondylotic myelopathy usually presents with progressive weakness. Okay,
Yeah.
and it won't cause any pain. It will be progressive. There will be evidence of atrophy and fasciculation in the lower extremities, and there will be evidence of spinal shock, steroid. There will be spasticity in the lower extremities with hyperreflexia and upgoing toes. That's the correct answer in this case. Okay. A 50-year-old man presents with gradually progressive weakness in the upper extremities over the past 6 months. Cervical MRI is shown. Based on the localization lesion on examination, what will you find? So this is the MRI. So what do you expect on the examination? He's got only progressive weakness in upper extremities. Patellar and ankle areflexia, sensory level below the line of the nipples, spared superficial abdominal reflexes, Horner syndrome, flaccid weakness of his lower extremities. Out of these 5 choices, you have to select one for this case.
Horner syndrome.
Yes, that's correct. Excellent. So he's got Horner syndrome in patients with spinal cord lesions above T1. You have to look for the Horner syndrome, and usually it is better if you follow this type of proforma to document in your day to day. This is usually the American Association of Spinal Cord Injury Proforma, international standards for neurological classification of spinal cord injury, but it has got a lot of information, and you can pick up and document your findings on this. So I think that with that we come to the end of our class here. Any questions or anything which we can share? Only thing that timing has been a problem now. I had to change the timing because of somebody's request, and maybe Sunday if you all have a class, then we'll have to fix it up some other time. Let's see how we can interact. So this is only an introduction to spinal cord disorders. We may take up more cases or like hereditary myelopathies and vascular myelopathies and immune mediated myelopathies. So non-compressive myelopathies will take one class more. Compressive myelopathies are covered in this mostly, and nothing is specific, but we may do the non-compressive myelopathies. And I have a chapter in APA textbook of medicine along with Dr. Venkat Brahman in I think a couple of editions back when we reviewed the non-compressive myelopathies in India. Thank you very much. Okay then.
Thank you, sir. Thank you,
Thank you,
sir.
sir.